Are we live?
Yes, sir. Yes, sir. We live.
Hi, good evening, everyone. So, welcome to this session. This is first on my behalf in terms of getting you through residency program, and I'm just going to take you through important topics that we discuss in clinical case scenario. So, the purpose of this session is going to be discussing clinical cases and also to let you know as to how to approach these cases both from the residency point of view as well as how these cases can be brought up in terms of management strategies when you go into practice. So, the twofold advantage that we are going to give you is not only prepare you for the important aspects of the various clinical scenarios from the exam perspective for MD medicine or DNB medicine, but also for entrance preparation for MDDM. And thirdly, an important advantage is a clinical approach to practice. If you end up practicing the cardiology or for that matter medicine and you encounter a clinical case like this, how are you going to approach? So in that session, in that continuity is what I'm going to do. The first thing is the HOCM. The why I'm doing HOCM, a lot of people will ask, sir, it's not the commonest thing that we encounter. We see a lot of ischemic heart disease, valvular heart disease. Why you're not doing this? Because I wanted a uniformity in what is available for free or as well on DocTutorial on YouTube. So my HOCM lecture for theory is anyway free, and you can go to DocTutorials channel, subscribe to it, and you can view the free video on HOCM. Also, the other aspect of HOCM is it's very high scoring topic. This is a topic that is asked all across the board, one or the other questions, whether be it Viva for the NEET SS, INISS interviews, or it be entrance questions that are asked at, let's say, MAVA Campton level or dynamic auscultation or genetic morphologies or variants of HOCM, which are usually you'll find one or two MCQs, short, +4 that you can score out of these. So what I'm going to do is that I will be taking you through a simple PowerPoint presentation of how typically a clinical case of HOCM would present. So I hope my slides are visible to you. Just share in the chat box if they are visible, or maybe a thumbs up if I can see. You can write in the live chat. We are live. If you can see in the live chat box, let me see if it's, you can see. Okay. Yes, so I can see some of you mentioning that you can see it live. Okay. So what I'm going to start with is how typically an HOCM presents, right? The clinical case, the way we discuss a clinical case presentation. So that's what I'm going to take you through. All right. So beginning with the typical HOCM presentation, that is how you would actually end up presenting a clinical case. So this is a hypothetical case, actually not classically a hypothetical one. This has been discussed in one of the residency programs with one of my students, actually presenting a case which I have slightly modified in terms of symptomatology, what I thought that I should be discussing out and actually telling you to unlearn and learn what how it should be presented. So I'm discussing a case of a 68-year-old married female Sita Ben housewife who started up to ninth standard. So typical is history presentation, as we know, name, age, gender, occupation, studied, socio-economic background would always be a part of history presentation. And very importantly, what you should understand that it should be in a formatted paragraph linguistic form rather than, name this, age this kind of presentation, because it's as much case presentation is an art as it is a science. And the art of presenting and appearing to be different from the rest will set you apart as to how you score more for presenting the same case to same set of examiners in a different format, in a different linguistic format. So for example, you may end up saying, respected teachers, I am presenting a long case of Sita Bain, who's a housewife, is aged 68-year-old, is married and had studied till ninth standard. This is one way of formulating the introduction paragraph. Other way would be Respected teachers, I am discussing a case of 68-year-old married female named Sita Ben, who's a housewife and had studied till ninth standard. So there are different ways of formulating and presenting these four important informations in different linguistic formats, and all you need to do that the examiner who's been monotonously facing the same stuff all since morning would be happy to hear a different language format of your presenting the basic information, and that would draw the attention of the examiner when you're presenting it as a long case in your viva. So this is one simple information that probably nobody else would be sharing with you, which I thought I should be sharing as an examiner that I've been to various universities where I uh, end up getting appealed, or also the trick that I used when I was a resident while presenting a case to sound different from the others, though I'm presenting the same matter as has been presented by other students ahead of me. So once you've done with the chief complaints, you would often be asked, or sometimes when you sound slightly different off track, the trick in the exam, I always say, is the play the psychological game as to who leads whom. Are you leading the examiner into the question that you want him to ask you, or the examiner is leading you to the questions he wants to ask? So how does that happen? It's simple trick. You over stress upon a certain aspect which can draw examiner's attention to ask you a specific question. For example, if you say a female, if I was to stress out 68-year-old married female Sita Ben, the examiner may be inquisitive. Why is he stressing females? And then do you think that there is a male female preponderance or gender preponderance for HOCM? And then you can say no. So that's an additional question that you could actually get. For same used to happen with a mitral stenosis versus mitral regurgitation. And as you know, mitral stenosis does have a female preponderance, but mitral regurgitation does not. And now overall, the valvular heart disease has been shown not to have any gender preferences. Same way you can talk about housewife, how does it limit, what kind of activities she does, or why the education is important. These can be some tricky questions that actually I've heard in MCH level people have been grilled upon, because the rest of the things they are pretty good at. So the other Viva Voca can actually go on, and I hope that someday I will be discussing those aspects too. But to stress upon, let's move to chief complaints that the patient usually of an HOCM presents with. So HOCM typically classically presents with breathless. The triology or the classical symptomatology of a patient of HOCM would include one, loss of consciousness because of an arrhythmia or palpitation because of it. So syncope, that may be one, which can often be the first episode of a sudden death or terminated or a fatal event itself, and the palpitation. But more importantly, because of the LVOT obstruction, there would be presence of angina. This is one of the cause of angina, which is non-coronary in etiology. So this is another Viva question that typically comes around as to what are the causes of normal coronaries with classical angina. And then sometimes if you're not well prepared to comprehend the question, you may get distracted. Even though you're presenting a case of HOCM, you may not be able to remember that you need to speak HOCM as the cause. And of course, the others being the LVOT obstruction in form of aortic stenosis, pulmonary stenosis, subvalvular membranes, coarctation of aorta. These patients, mitral valve prolapse, coronary emboli, myxoma emboli, all these conditions can have angina despite normal coronaries. And then if you are intelligently trying to place this question, you can talk of something like Minoca, Inoca, etc., which is beyond the discussion of today's talk. The other complaint, because of the fixed dynamicity of the obstruction and limitation of the activity, could be because of occurrence of the breathlessness or dyspnea on exertion, and the palpitation giddiness, as I say, would be part of the arrhythmias. So once you're describing the same, you would be looking at ODP, which would go in terms of description again. You would be restricting to the origin, duration, progress, and it would be often described in terms of a paragraph again. So, like the history can go, patient was apparently asymptomatic 2 years back, and then she started developing breathlessness exertion. Initially noted while walking around 2 kilometers to a nearby temple and on climbing 2 flights of stairs, which was relieved by taking rest like NYHA class 2. Breathlessness then gradually progressed to doing household activities like going to washroom, dressing or undressing herself, which is class 3, and relieved by taking rest, which was not associated with cough expectoration or seasonal variation. To differentiate it from respiratory etiology are the same. It again also you can mention whether the patient had or did not have associated orthopnea or PND. Typically, HOCM does not present with PND. So can you text me and let me know as to why these patients don't present with PND? HOCM rarely ever has PND. So put a message in the live chat box as to why the patients of HOCM don't develop PND. I'm waiting. If you guys can reply back in the live chat why these patients don't develop PND. HOCM, the PND is very rare. Remember, the PND would happen because of interstitial edema. HOCM is a diastolic dysfunction. It's not a systolic dysfunction. And in sleep, the pulse rate actually goes down. And because of that reason, the amount of and the sympathetic activity goes down. And hence the LVO and the patient is supine. So LVOT obstruction actually reduces because the patient is supine, the venous return is more, the LV cavity is bigger. Also, the heart rate is slower, sympathetic tone is lower, and hence the wedge pressures will actually fall. That's why a patient who's previously symptomatic on activity would not be symptomatic, sorry, would not be symptomatic in sleep or PND. All right. So she restricted her activities and remained asymptomatic with restricted activities. Patient also developed exertional chest pain since 1 year, left-sided constrict. And then once you describe any symptom, you would describe it in terms of what is called as an acronym that I call script FADO. S for site, C for character, R for radiation, P for precipitating factor, intensity, time, factors aggravating, and duration and origin. So that's the acronym. You can create your own acronym for it. So these are the acronyms under which you can describe a chest pain. So all those descriptions should be complete. You should not say typical atypical angina, which is the old name of classification, but now you need to describe it classically as it was left-sided, anterior part of the chest, constricting, localized, relieved by taking rest, or with nitrate. So remember, one of the inguinal pain that actually worsens with nitrates is that of HOCM. So you may be again be smart enough to tell them that this patient took, if the patient did take sublingual nitrate and angina did not improve. So again, this way you're leading the examiner to ask you as to what are the other causes of chest pain that can be relieved with nitrates, or what are the causes of chest pain which get aggravated by taking nitrates. So nitrates are harmful in which angina. One is HOCM. Again, it's an open question. If you can drop a message in chat box as to why a patient of HOCM will have worsening angina with sublingual nitrate. I'm waiting for your comments in the live chat box. So apart from HOCM, other conditions where the angina worsens is RVMI, right ventricular myocardial infarction, because that's a preload dependent situation again. So if the preload goes down with nitrate, the pressures will go down further and the coronary perfusion will hamper further. Extending the same logic, because nobody answered right now in the live chat box as to why HOCM angina would worsen with nitrates. Again, it's the same reason, because the LVOT obstruction will increase. Because remember, in HOCM, the obstruction is dynamic in nature. Anything that will cause LV cavity to become small or force of contraction to increase will increase the obstruction. That's the basic mechanism. So if you've gone through the lecture on HOCM of mine on the app or the free lecture that's available on YouTube on the DocTutorials subscription, you will see that the dynamic auscultation has been explained how the murmur of HOCM or obstruction of HOCM worsens on standing, and so also Valsalva. So anything that decreases the LV size will bring the outflow and the mitral leaflet more into the outflow track. The SAM will increase. The cavity is small, so already narrowed outlet orifice is further narrowed and the obstruction worsens. And that is why anything that decreases LV cavity, whether it's by standing and reducing the venous return, or sublingual nitrate, which will further reduce the venous return by falling the venous pressures, This will lead to worsening of obstruction and hence worsening of angina. So this worsening of angina, apart from HOCM, it can also happen in aortic stenosis. There, the mechanism is slightly different. The mechanism of angina in a patient of aortic stenosis is because of the fixed cardiac output. The amount of blood that will go out of the cavity is fixed because of the narrowed orifice. The valve area is the ultimate determinant of how much blood will go. Now, if you reduce the preload, this will further, the orifice will allow X amount, but the amount of blood that will go out has been reduced, and hence, on top of it, there may be either no effect or slightly worsening of hypotension and hence worsening of angina. So there, it is not the classical mechanism of vasodilatation in the coronary bed relieving the angina. The worsening of angina is primarily because it's of the demand supply mismatch or LVOT obstruction causing worsening. Also, she had multiple episodes of giddiness 1 month back, which was not associated with loss of consciousness and preceded by sense of imbalance, lightheadedness, but not associated with visual, auditory, jerky, or involuntary urination or defecation. Now, why these are important? Because you need to differentiate between a neurologic and a cardiogenic syncope or pre-syncope. Now, remember, there are EGASIS criteria which can help you to differentiate, but roughly to say four important predictors are convulsive movements, aura, post-ictal confusion, duration, which is in few seconds in cardiac. Because you cannot have a cardiac syncope lasting for 10 minutes. Vasovagal is one which is an overlay of both neurology as well as cardiology. That's where your duration may be slightly different. But it's important that you also talk about negative histories, which is no hemopsis, hoarseness of voice, bluish discoloration, prolonged fever, migratory polyarthritis, edema of feet, abdominal pain, decreased appetite, and so also that of the hypertension since for a past history, whether the patient is hypertensive or not hypertensive since 4 years, on regular medication or not on regular medication. So those negative histories will be important. So past history, patient had history of hospitalization 3 years back for typical chest pain, admitted discharge on medication after 3 days, which was discontinued later on. Then you have to come to your after past history, personal family history, which is again something that you've really well been trained in undergraduation. So I'll not stress upon each of them. Maybe in some live session we can do. So for the previous question, we got answer from CK Ank that the no increase in LVDP can cause systolic function to be normal, and reduced VR will reduce the size of the LV cavity and increase LVOT obstruction. That's very much correct, and that's the explanation I gave. Thank you, and congratulations for the wonderful correct explanation for the question that I had asked. After the history summary, once you're presenting a case and you're done with the classical description, you're often asked to summarize the history. So the classical history summary needs to be bringing out the possible etiology and explanation. 68-year-old hypertensive female with exertional breathlessness gradually progressed from class 2 to 3 over 2 years. Exertional chest pain gradually progressed from class 2 to 3 over 1 year with multiple presyncope episode not associated with loss of consciousness over a month. That would get you as to where you are leading this patient to. So you're talking about two important symptoms. One is angina, other is dyspnea associated with arrhythmia. So these three combo in a 68-year-old would lead to certain possible etiologies. One of them that strikes you most commonly would be that of a possibility of a patient having ischemic heart disease, because a 68-year-old female would classically present with ischemic heart disease, or in a patient of HOCM, which is the other differential that we are talking about. So possible differential, as I said, would be structural valvular heart disease in form of LVOT obstruction, either because of HOCM or aortic stenosis or arrhythmic cardiomyopathy. Now, this is a new terminology which is called as ACM, arrhythmic cardiomyopathy. A lot of times the differentiation that is being given is arrhythmic cardiomyopathy, and there may be ischemic cardiomyopathy or RVOT obstruction can also present with the same. So then you come to general examination. The patient is conscious, cooperative, well-oriented, time-placed person, well-built, nourished, height, weight, BMI, what is called as an acronym, no JCOL, which is pallor, clubbing, J for jaundice. Jaundice is not the word that you use. You use word icterus, but this is just an acronym to remember. So pallor, clubbing, cyanosis, icterus. I'll definitely be interested in knowing for each one of you how in HOCM or in an LVOT obstruction, why this would be important. So you should be prepared for it. I'll definitely be trying to answer them. You can WhatsApp me personally. I'll keep that open for you guys to think about, analyze, and ask yourself how can an HOCM patient develop either of these or a combo of all of these. No marfanoid features, infective endocarditis or skeletal abnormalities, and back and spine being normal. Then you come to vitals, where you are very importantly looking at pulse of 64 per minute, whether it's regular or irregular. You should also be looking at cardiovascular examination. You can go to my lecture on clinical examination, which is taken in full 1.5 hour length of cardiovascular system. This is again a video which will help you how to do a clinical examination, how pulse should be mentioned, how you differentiate various types of pulse, how they help you in arriving at differential diagnosis. So also a lecture on JVP, blood pressure, dynamic auscultation, which all will help you in assessing a clinical assessment of a case. And it's very important for the exam perspective as well. So you look at the various pulses, bilateral carotids, if they're palpable, non-collapsing, all peripheral pulses are felt equally, no radiofemoral or radioradial or brachiofemoral delay, respiratory rate. So classically, you often tend to say that carotids, you expect HOCM to come with a pulse character, which is, can anybody text me again? What is the likely expected pulse in a patient with HOCM? It's BIS variance. But remember, this BIS variance is a recordable BIS variance, not a palpable BIS variance. So you may get BIS variance. And again, the next question that you may be asked is, how do you differentiate BIS variance of AS with AR from an HOCM? So the aortic shudder or the shoulder that you get, spike and dome pattern as it is called, is the one that helps you to differentiate between the two. And then you may also be asked to give the reason why the two pulses are different. AS with AR, moderate AS with severe AR, which also gives rise to BIS variance, and HOCM BIS variance. Why the characteristics are different in both of them, though, despite both being BIS variance. Again, I leave that for you to reply back to me on WhatsApp or personally text me, or on the app. You can contact me and explain to me. Else, I will give you the answer why the pulse are different in both, though being BIS variance have a one has a spike and dome pattern, the other does not. Spike and dome is seen in HOCM, but not seen in aortic stenosis with aortic regurgitation. Why is it so? That is something that you should think and ponder about and explain to me. So blood pressure was measured, and that should be mentioned in all four, which was normal. Also, it's important to look for all four limb saturation. JVP needs to be mentioned. That's 5 centimeter above sternal angle, 30-degree, head up, pulsatile, prominent A. And then you come to systemic examination. So systemic examination will talk about the chest symmetry, that it is bilaterally chest symmetrical, AP transverse ratio you need to mention, and of course transverse will be more than AP diameter. Apex, where is it visible? So it's visible in left fifth intercostal space. A lot of times inspection and palpation is combined and spoken as one examination, which is also okay. The inspectory findings being confirmed on palpation. But if you go separate, even that is fine. No other pulse and scars, because that's the only thing. Anyway, the pulse has to be confirmed on palpation. So these findings are confirmed. And the classical description of the apex beat in a patient is a LV type, of course, but it's a heaving in character. The classical description is what is called as triple ripple, not even double impulse. You can actually have the two obstructions, the two beats of the LV. First is the initial force of contraction of the pressure overload, and second is when it overcomes the obstruction. So two contractions will come, which is called as bifid LV impulse. And on top of that, you may have the impulse of the LA, because LA is very stiff. So this three impulses can give rise to what is called as a triple ripple. So it will be an LV type of impulse. How do you identify LV type of impulse? By medial retraction. The RV which is present on the right side, it retracts earlier than the LV impulse which is pressure loaded. So it's heaving because it's forceful and sustained. So again, in clinical examination, you can go back to my videos of clinical examination where I've explained how do you identify heaving from hyperdynamic apex beat. You can also learn the same on the residency programs as we train you and demonstrate the heaving from the hyperdynamic apex. Double apical impulse is also palpable, as I said, because of the obstruction in palpable S4 and no palpable S2, S3, no thrill over precordium. The percussion, the very important thing in cardiology is establishing situs. When you percuss in the right midclavicular line, you percuss the upper border of liver where it is present on the right side or not, because that will go with situs solitus. Lot of times in a patient with congenital heart disease, you may have situs inversus, and what you're describing may be the other way around. Left heart border would correspond to rule out any pericardial effusion. Right border is usually substernal, and second left should be resonant because there is no pulmonary hypertension. Second left stern intercostal space becomes dull only in three conditions. One, dilated LA appendage, dilated PA, which is in pulmonary hypertension, and three, pericardial effusion. Only three causes where you get dull second left. So patient either has PH or has LA or has fluid, either of the three. So all three are ruled out if you have second. So that's one of the important. Situs and the second left are two important percussion findings. The rest, otherwise, they say can be done away in cardiology. The percussion has no value beyond these two. Coming to auscultation, which is very important, is to know dynamic auscultation in an HOCM. So the murmur will change in quality in supine versus standing, Valsalva versus no Valsalva, inspiration versus expiration, leg raise versus no leg raise. So you can go through the description of dynamic auscultation in our lecture, which is separate lecture on dynamic auscultation in residency program. Also, you can go through that lecture on clinical examination where I've covered dynamic auscultation in videos, or you can listen to a lot of videos on clinical examination that we have covered. So S1, S2 normal, narrow split, S3 absent, S4 would be loud because of the stiff LV against which the forceful LA contraction is happening. Harsh ejection systolic, high pitch grade 4/6 intensity murmur, which is audible in the left third intercostal space, close to sternum with diaphragm of the stethoscope, which increases on standing and strain of Valsalva, which will both decrease the LV volume, and decreases on squatting and hand grip because of increase in the LV size, and they don't radiate. That's how it differentiates in a murmur of aortic stenosis. The valvular obstruction would radiate to the carotids, but that of the subvalvular obstruction will not. Apart from the site and dynamic auscultation, the radiation is another important feature that helps you to differentiate LVOT obstruction of HOCM from obstruction of aortic valve as the AS. Pansystolic blowing pitched, high pitched murmur, a murmur grade 3/6 of MR may also be audible radiating to the axilla because of the anterior SAM. The anterior leaflet goes away. There is an orifice gap left, which causes the MR to happen. You have to finish exam with other systems. Remember, you are not looking at just the cardiovascular system. Complete examination should talk about other systems, respiratory, abdominal, and CNS being normal. So then you arrive at the diagnosis. Leela, and what does she have? She has structural heart disease with dynamic LVOT obstruction in form of hypertrophic obstructive cardiomyopathy with diastolic heart failure in NYHA class 3, which you derive from, of course, from the dyspnea class, without signs of PH and in currently normal sinus rhythm. So then you will be asked as to justify why this is. You may be asked about differentials of LVOT obstruction. You must remember the three variants of subaortic stenosis. What are the three variants? One is HOCM, of course. The other two being the funnel. The subvalve being having a one is a membrane. The other membrane apart. So membrane, how is it different? You will have some murmur of aortic regurgitation because membranes are usually attached to the aortic leaflet and they cause some amount of aortic regurg as well. The tunnel variant, as they call it, there is the LVOT is elongated and tubular, and then you can have a hypertrophic dynamic, as we mentioned, of the HOCM. Those are the three variants of subaortic stenosis, three variants of subaortic stenosis, as they are mentioned. So you can have a classical X-ray where you may not have the post-stenotic dilatation of ascending aorta in HOCM. That's how it will differ from the X-ray of aortic stenosis. This is an ECG where you can see the HOCM, the LA enlargement. You can see the P waves biphasic in the lead V1, and there is ST depression, and there are pathological Q waves in the mid-precordial leads. So you need to rule out ischemic heart disease. There should not be loss of R waves in V2, V3. Also, it may be because of improperly placed leads, and there is a bradycardia as well. So when you arrive at a diagnosis, you will be asked the further approach, Previously, examination used to end at coming to diagnosis. Now it goes beyond X-ray ECG. You will be asked to do echo in cardiology, especially. In MD level, you may not be asked to do echo, but you'll be asked about the treatment and investigation plan. So apart from routine investigation, that's how the standard line is. You would like to do echo, cath, and then start the therapies. Very often the questions would go around novel drugs, which is a lead a trick question, which is mavacamtan, which is a myosin kinase inhibitor, and this because of its action inhibits the contraction and cross linkaging between the myosin fibers and the forceful contraction, and hence it reduces the LVOT gradient in the Explorer HCM trial, where they found out the gradient reducing significantly. Also, the two therapies that have been used in these patients is myectomy, where they surgically remove the LVOT thickened septum, or alcohol septal ablation, where they inject alcohol in the transcatheter procedure into the first septal branch of the left anterior descending artery and cause myocardial necrosis and injury there. So this is from Brunwald's. As you know, how do you screen a patient? Family that does not have known pathologic or like pathologic variants, you just do ECG echo. In children, initial screening can commence at any time, but no later than onset of puberty, and then you need to repeat every 1 to 2 years. Same is the case with adolescents. In adults, however, at the time of diagnosis of the first case, you also need to look at the first degree relative of this patient and repeat it every 3 to 5 years. But in a family that's known to have genetic problems of sudden death or suspected HOCM, you must do a cascade genetic testing. Relative that does not have the family history of HCM, confirm the variant pathogenicity every 3 to 5 years. You can variant downgrade to benign or likely benign and then revert to the same protocol as we did for somebody who. But if the relative does have somebody who's got a family variant, you'll have to comprehensively do HCM patients. Other thing is to whom to put in a ICD. So IICD is to be put in all patients if there is a prior event. If somebody who had a sudden cardiac death survivor, who had a documented VT or had a sustained VT, you must put an ICD. At least one of the following is important. Like the family history of SCD, massive left ventricular hypertrophy where the thickness is more than 21, unexplained syncope, apical aneurysms, EF less than 50%. All these would qualify. If any one of them is present, then it is reasonable to put an ICD. Also, if there is a documented NSVT, whether it's a children, then you must do, and if it's adult, even then it can be considered. In children, it's class 2A. In adults, it's class 2B in an NSVT. NSVT does not make it class 2A for adults. The looking for the MR, cardiac MR for late gadolinium enhancement is a class 2B indication. But if it's not there, then it should not be advised to put an ICD in these patients. So in symptomatic patients who have symptoms, non-obstructive HCM, just beta blockers are good enough. If you can't give beta blockers, put them on verapamil diltiazem. If dyspnea persists, you can add diuretics. Remember, these have to be very low dose diuretics because they are preload dependent patients. Low EF, of course, you'll have to treat when it's a burnout HCM becomes a dilated cardiomyopathy. You give the 4 pillars of heart failure. Normal EF, you have to treat like HFpEF. Again, very important, as I said, avoid vasodilators. Don't give nitrates. Don't give ACE inhibitor. Don't give ARNI to these patients otherwise. If the symptoms persist and there is persistent gradient, especially if the obstruction, disopyramide is a good drug. Now, mavacamtan is available in US, not yet available in India, but disopyramide is easily available. It also reduces the gradient. You can do a septal reduction. In surgical candidate, you can do myectomy or ablation, or if it's a not surgical candidate, you can do a septal ablation. So septal alcohol septal ablation is the trick in these patients. So that brings us to the end of presentation here. I will now close this session and we can go to question answer. If there are any questions, you can put them in the chat box and I will be glad to answer them. Else, this was a brief introduction as to how we are going to run this program about residency, how we will be taking you through not only the guidelines, but also take you through important aspects of management strategies, of important disorders that you may have to be treating in your practice. And also, we will be taking you through preparing how to present a case. And of course, you can personally connect with me and drop me a message. You have my number. You're added to a lot of WhatsApp groups that we are teaching you, where we can discuss out the important aspects. So, if there are no questions, then I can end the session. I'll wait for a couple of seconds for someone if there are questions to be raised. So CK Ankit has all mentioned about bispherians, spike and dome. I beautifully answered all those questions. All right. So that should end our session now. Thank you very much and good night and take care. Stay connected. Bye bye.